How many are in the process of selecting or implementing an electronic health records, have not selected an electronic health records? How many have an electronic health records in place? Just a couple. So just a curiosity, those who have an electronic health record in place, what's your intention of attending this session? Since there's a focus on selecting, are you thinking about replacing, updating, upgrading? What's the thought process? Just curious. Curious, okay, great. How many have implemented telehealth and remote patient monitoring, whether it's video-based telemedicine or telehealth, remote patient monitoring for chronic conditions and so on and so forth, and have it in place? This is actually expected. We have just conducted a national survey of the largest 100 aging service providers in partnership with Ziegler, an investment banking that invests in not-for-profit, primarily not-for-profit communities. And we found out that at the corporate level, 75.5% have implemented electronic health records, but only about 18% have implemented telehealth and remote patient monitoring. And that's, again, at the corporate level, which gives you, given the variation in the adoption rate, it gives you significantly higher perceived adoption rate than at the community level. So the session objectives today is to walk you through some of the steps that we've taken and the EHR initiative that we've launched in 2011 and the update that we've done earlier in this year, and also how we applied the same approach to telehealth and remote patient monitoring. Those of you who have been in the general session saw what I presented on the strategic scenario planning exercise that CAST conducted in 2011. And because we've identified interoperable electronic health records and telehealth as two key enabling technologies, we focus on our efforts on producing these hands-on tools. The approach that we've used is, in both initiatives, we pulled together a work group. We didn't want this to be sort of mandated or dominated by the vendor community, so we pulled work groups from representatives of providers, both providers who have been down that path, who have significant experience in electronic health records and telehealth and remote patient monitoring and have implemented these technologies, as well as others who were starting to explore that area, wanting to learn more, because we thought that they would bring a significantly important perspective as we try to evaluate. We can capture their thought process on how they are looking at the different technologies that are available out there. So what data elements, what areas of interest, what specific data elements we want to capture from these vendors, and then we gave the template to vendors. They completed the information. We shared it across all vendors to have a cross-check from other vendors, just to help us detect if someone is not telling the full truth about their product. And also, again, the providers who have used those products can verify whether these functionalities and features are available or not. So each portfolio has 4 components. The white paper, as I said, walks the providers through the most important planning steps that they need to consider, and the most important features to look for in an EHR, and then a detailed selection matrix, a bit overwhelming as a selection matrix. I have to admit this, but this is exactly why we did the third component, which is an online selection tool that makes the selection process really easy. All they need to do is go online, select the care setting that they want the EHR or the telehealth solution for, and then select the most important features, the must-have features they're looking for in these solutions, and it will hit search. It will give them a short list of only the products that meet those specifications. And then we know how important it is for providers to learn from peers, from others who have been down that road. So in both initiatives, we invited participating vendors to nominate a provider, to submit a provider case study from their perspective. What problems they were trying to solve, the approach that they've taken to solving that problem, how they went about selecting a solution and implementing a solution, and not only the impacts and the outcomes that they've experienced, but also the good, the bad, and the ugly. What lessons they've learned, what pitfalls and advice they have to share with others. Because again, I believe that we can learn a lot more from negative experiences than simply focusing on positive ones. After we did the first 2012 EHR initiative, we asked, this is the approach that CAST has been taking for the past couple of years, we embedded an online survey in the results and encouraged those who use the online tools to provide us with feedback. We've gotten 55 responses. We wanted to see how the initiative, how they evaluate or value the utility and user-friendliness of the initiative. 73% find the significant need, that the EHR initiative filled a significant need. 75% found the white paper extremely useful and useful or extremely useful. 62% found the case study useful. 27% had not had a chance to read the case studies at the time. 62% thought the online selection tool, again, was useful, and 22% did not have a chance to experiment it. What is really important is to see how many page hits we had on that tool. Since its launch in 2012, we've had around 11,000 hits on that tool, which means that it's gotten popular, but not many, as you can see, provided us with feedback. Towards the end of the survey, we asked providers to give us feedback on what CAST should be focusing on. And 94%, we suggested telehealth, because again, based on our strategic scenario planning exercise, and 94% agreed with us and said we should focus on telehealth. Now, the EHR white paper itself is based on two excellent tools that Stratus Health, the QIO of Minnesota, have produced back in 2010, I believe. They had two tools, one aimed at skilled nursing facilities and one at home health and other care settings. But the feedback that we've gotten when we started promoting those tools, the feedback that we've gotten is that the process is too overwhelming. It's about 176 pages of forms and text and Excel forms. So we thought that we needed to do something differently. We decided to summarize the most important points from those two toolkits and provide links where appropriate to the relevant worksheets or the relevant Excel sheets for providers to use. And essentially, the process starts with assessing where you are, assessing the infrastructure that you have, the networks, the switches, whether you have wired or wireless, whether you have a server room, whether you want to have that EHR locally hosted by you, whether you have the staff availability and staff competencies on the technical side, right, on just supporting the EHR. And also look at the staff competencies, the clinical staff competencies and comfort with using technology, with using computers and so on and so forth. And then looking at the current processes and workflows and the types of forms and documentations that take place currently. And then from that stage, the white paper walks you through the planning process. And it starts with pulling together a multidisciplinary team of, implementing an EHR is never an IT project. It's a multidisciplinary team. You need to pull the clinicians, you need to pull the financial and management people, administrators, and you need to have a significant buy-in from the top, from the top management. And these 3 different or 4 different stakeholders should work together on setting SMART goals, goals that are specific, measurable, attainable, realistic, and trackable in each one of these areas. And then they need to work together on, if we automate, if we implement the workflows and the forms that we currently do, we just put them in computers, we haven't done anything. We have seriously impaired ourselves from taking advantage of the efficiencies that the electronic health record would offer in terms of inputting the piece of data once and using it multiple times in different, by different team members and in different screens and so on and so forth. So we really need to think about workflow and process redesign as we think about, as we document the current status to take advantage of the electronic health records. We need to do that internally, and we also need to keep our eye on the prize, on the future, in terms of what do we currently do when we send a patient to the hospital or when we receive a new admission? What information do we currently get? What information is missing? How do we need to redesign the workflow outside the walls of our community or outside our facilities? And then we need to work on selecting, again, based on the infrastructure that you have and the competencies and that you have in terms of hosting capabilities and providing technical support capabilities, being able to do the backups. If you have that capability, that's fine, then a local hosted model might work for you. But if you don't, or you feel that you're short on that, you need to really think about a SaaS model or a software as a service model, and you need to offload that burden of hosting on your EHR vendor, or in some cases there are third-party vendors who do the hosting for you. And then in the process of planning, you need to decide on what must-have features you want. Do you want your electronic health record to have a medication management clinical decision support system? Do you want it to have certain interoperability characteristics or features, implement certain interoperability standards like, for example, the NCPDP 10.6, which allows 3-way electronic prescribing between long-term care, a pharmacy, and a prescriber. We stopped at the implementation. We give general guidance on the implementation, but we felt that the implementation is going to be so bifurcated by the type of system that you end up selecting and implement. So once you implement, of course, there are steps that you need to take in order to interoperate, but we also want to encourage our members on not only select an electronic health record to improve the timeliness and accuracy of documentation, but also to use the data in improving and driving quality improvement initiatives, in using the data for quality reporting in copy, and also to drive improving quality of care, reducing, for example, hospital readmissions, reducing inappropriate hospital transfers from nursing homes, and so on and so forth. In the initial version, in the initial matrix, we only asked vendors whether they provide clinical decision support systems or not. In the new one, we looked at every single one of the clinical decision support system capabilities that we're aware of, like the interact or inappropriate hospital transfers, medication management, falls or falls reduction, pressure ulcers, prevention of healthcare acquired infections, and so on and so forth. And again, looked at we hear from a lot of our members that their challenges is implementing a financial system separate from the e-prescribing system or medication order system, separate from the EHR, separate from the MDS. So we looked, and also for multi-sites, being able to see and pull information and integrate information and have dashboards that tells them what's the status of the different campuses, right? The census and so on and so forth. So we focused on integration and interfacing, and we revamped that section significantly. Another question that came up after we did the first was, okay, so there were 22 vendors. Which ones are likely in this sort of quicksand environment and vendors popping up and vendors sort of disappearing? Which ones, and given the significant investment, which ones are likely to remain after we make the purchase decision and would be able to support our system and be in business? So we also added a section looking at the company's experience and viability, how long they've been in business, how many clients do they have, and what's their strength? Is it in skilled nursing, in CCRCs? What's their sort of strength area, and so on and so forth. So based on this, we had 36 EHR vendors participating in our initiative, including the big ones like point-click care and AOD and health medics and so on and so forth. But we also captured new entrants into the market. For example, Cerner, who just launched an electronic health record for long-term and post-acute care, based and built upon their acute care platform as well as their CNA documentation platform. And we also looked at one of the care settings that we did not look at in the initial one was PACE. So we looked at electronic health records specifically for PACE. So generally, based on this, the data that we collected, the 36 EHR vendors we captured represent about 75% or 74% of the total number of EHRs, full-blown EHRs, not just MDS or OASIS documentation software, which we estimated to be around 49, that has the clinical notes, diagnosis, and so on and so forth. Based on the data that they reported, they have presence in over 45,000 facilities. Now, if you look at the total number of facilities in nursing homes, assisted living, CCRCs, hospice, home health agencies, and PACE sites in the US, it's a little over 50,000. So they capture 90% of the market. That doesn't mean that we have a 90% adoption in the market at all. It means that the reason for this high perceived percentage are twofold. Number one, some of these companies are international and they have clients outside the US, mainly in Canada, Australia, and the UK. The other reason is the fact that because of the fragmentation, some of these have modules installed in many, alongside other modules from other EHR vendors installed in these facilities. We also looked at the different care settings. We have 92% would work for skilled nursing facilities, 83% would work for CCRCs, and so on and so forth. But we also looked at which of those, what's the percentage of all of these EHRs that serve all of these settings, and it's about 8%. 8% of these EHRs can work for you across the continuum if you have multiple operations and want to have a uniform or the same platform essentially across all your settings. Again, along the same line, we looked at the regulatory, mandatory assessments that you need to do for the different care settings. 83% again do the minimum data set. I don't know how the remaining percentage, if they don't do the MDS, they must be doing, or they must have a partnership with another MDS documentation platform, right? 81% do the care area assessments, 33% do the IRF-PI for inpatient rehab facilities, and 28% do the or serve the home health and do the OASIS. Again, only 11% can do all of these assessments. Clinical decision support systems, 67% do medication management, 56% do falls management, and the same with pressure ulcer. Inappropriate hospitalization and hospital readmissions, 42%, 39% implement the Interact, the acute, inappropriate and acute care transfer tool in one way or another, not necessarily fully licensed by Interact, because we know that initially Interact licensed its tools to a single vendor, but now several other vendors have managed to obtain official licensing from Interact from Florida Atlantic University to implement the Interact tools. 36% implement infection reduction, and 31%, which is a really good percentage, implement all of the above clinical decision support systems. But there is a difference between what they have in the EHR and in terms of capabilities and what providers are actually using, right? So keep that in mind. We're just looking at the capabilities rather than the actual usage. In terms of drug therapy, we looked at the system's ability to implement electronic medication administration records. That's a high percentage, 97%. Being able to, through the EHR, to do medication orders, 92%. In terms of closed loop verification of the patient at the point of care when they are given the medication using, for example, the barcode system, scan the medication package, scan the wristband on the patient to ensure that we're giving the right medication to the right patient. This is relevant, of course, to skilled nursing facilities as opposed to the other settings. 78%, they said they have the ability to interact or to integrate with barcode verification systems. 75% said they implement and can do three-way electronic prescribing. And when you look at all of the above, 64% said they can do all of these functionalities. So that's, again, a really high percentage of EHRs that can handle drug therapy from upstream at the prescribing point or medication order point all the way down to administration. In terms of interoperability, again, we looked at the ability to connect to health information exchange at the state level or to a regional health information exchange. 64%, they said they have the capabilities. Again, are 64% doing it? No, of course not, right? But they do have the, under the hood of and the engine under the hood has implementation of basic interoperability standards that allows them to do this, but they haven't really been doing it. 58%, they said they have the capability to interface with hospital discharge systems. 47% said they have direct or support direct provider-to-provider transfer of care and shared care. 31% said they can export to a personal health record. This is, again, important in the light of health reform and the importance of engaging the consumer in healthcare decisions and informing them about healthcare decisions, and maybe potentially, eventually, getting them to input information into the electronic health record through a client or resident portal. 19% said they have all of these capabilities. In terms of certification, there are 3 programs of certification available. One for meaningful use, primarily geared towards providers who are eligible for the CMS EHR adoption incentives, and these are applicable to hospitals, acute care hospitals, and other hospitals, critical access hospitals, and so on, as well as healthcare professionals, namely physicians and physician assistants. They're not applicable, the meaningful use program is not necessarily applicable to long-term post-acute care because they don't get EHR adoption incentives, but we're emphasizing them because they're really important in terms of partnership with the hospitals. They would allow your organization to help the hospital partner become a better, meaningful user of their electronic health record if you have that certification and you actually do use that health information exchange capability well. So in terms of the CCHI, meaningful use, it's the bottom one. 8 out of the 36 initially had meaningful use certification. Just before I flew out a couple of days ago, I believe Point Click Care have received meaningful use certification. So that's a little over 2 in 9, and we have 9 EHRs that do implement this. There's 2 voluntary certification programs geared towards long-term and post-acute care from CCHIT, the Certification Commission of Health Information Technology, one geared towards home health and one geared towards skilled nursing facilities. So we have 3 certified in each one of these areas, and 3 certified in the home health, and 4 certified in nursing home, and 3 certified in both CCHIT programs, and again, 3 in all certifications. 56% said they have a fully integrated system that includes financial, ancillary clinical systems, like the interface with the pharmacy, the interface with the lab results and lab management, and also human management. 92% said they can integrate data from multiple sites, pull information and produce them. 86% said that they can produce dashboard views for upper management. Only 47% they can provide all of these functionalities. Again, especially on the multiple site integration, it's really important not just to look at the capabilities and the feature, but to ask the vendor to demonstrate that for you. If it's going to take you 12 clicks to get to that view, or it's going to take you to import Excel files and do them on a separate package or a separate screen, that's not really full multi-site integration in my book, right? So you need to look at these things when you do your due diligence, after you narrow down and select the few that you want to interview, during the interview, and also during interviewing the clients that have implemented this. Hardware, software, almost all of them provide remote access to clinicians, again, over a smartphone or a tablet. Mobile support, again, 78%. Local access only, and this is related only to locally hosted models. 69% are still offering that. So this is what the tool looks like. I'm gonna stop here and take a minute to take you to demonstrate the tool rather than talk about it in the abstract. So does anyone want to help me drive this? Go ahead. We provided the definition, right? But again, there's always room for interpretations, and we try to limit that as much as possible. So anyone wants to help me drive this? So we start with this we recommend that you read the white paper first, and that you then go through the planning process, select your must-have features, and then come to the online tool. Anyone interested in implementing an EHR in their facility? No? Okay. Let's assume that you have a home health, skilled nursing facility, a continuing care retirement community, You need service delivery record for Medicare, of course, because you serve the Medicare population. You want physician documentation to be part of the system, nurse practitioner documentation, history and physical, other professional consultation, progress, diagnosis, and pharmacy drug review, right? Drug therapy, you want EMR, ETAR, you want e-prescribing. You don't need closed loop verification, and you're not interested necessarily in medication adherence at the individual level. And you can see that there are 4 systems or 4 products that meet the criteria so far. Discharge documentation, I need discharge summary, I need clinical decision support system. Let's focus on readmission first and leave it at that. I need an integrated system. And once you, because you have an integrated system, you don't need to focus on any of the other parameters. I need interoperability and both direct and through HIE. I need, let's say, just CCHIT, meaningful use certification by ONC. I don't care about the model. I need remote access, and I need mobile device support. The system searches and then comes back to you with a short list of only the products that meet those criteria. You can refine, you can do a new search, you can print, and if they submitted a case study, you can view their case study. We provided a link directly to their case study. As I said, we focused our case studies this year on primarily the use of clinical decision support systems and the impacts of doing that, as well as health information exchange. And your opinion counts. We would like, at the bottom of the screen, there's a feedback survey. We would like to learn from you how we can update this tool and what else we need to be focusing on next. As I mentioned earlier in the presentation, I was crazy enough to do the same thing for telehealth, and we did the same thing and created a tool. I want to also go back and demonstrate that for you. Sure. Mm-hmm. Yes. No, we just asked about that. We did not, because again, you have 36. Look at the explosion of combinations that you can have. 36, and how many different third-party in each one of those areas. The HR, the financial, the ancillary clinical. We would have to have a matrix that is really much bigger and much more complicated. Absolutely, absolutely. You need to then go back and look at the matrix in details, right? That's the next step. You look at the details in the matrix. You decide which ones you want to invite to come on your campus and do a demonstration. Get a list of references and call up some of your peers. Use and utilize the CAST listserv to ask your peers about their experience with this particular vendor, and they can provide you with this feedback. Again, we did the same thing on telehealth. We reviewed 23 products from 16 vendors. You can do the same thing here. The difference is we added physician offices and hospitals, because you may want, well, you have to sort of do, especially if you're doing video-based telemedicine, you have to do it in partnership with an acute care partner. So we added some acute care settings here to cater for integrated care delivery systems, right? And we added care delivery systems. And you select what kind of telehealth you want, whether it's interactive voice response systems only, or biometric remote patient monitoring, only, or ones that have other store and forward types of systems, like the ones that include imaging, include monitoring activities of daily living, safety, sleep, and so on and so forth. You select the embodiment based on your care settings. We're advising those who are in congregate living settings to utilize the kiosk embodiment in putting them in common areas, as opposed to putting a telehealth unit in each apartment. That is a much more cost-effective approach to these. And then you select the conditions that you want to monitor for, and based on that, it tells you what kind of ancillary devices you want the telehealth system to have, whether it needs a stethoscope, temperature probe, blood pressure cuff, weight scale, and so on and so forth. You select those, and what kind of program support you want the vendor to offer. Some of them offer remote or telehealth nurse services. Some of them offer to send the equipment directly to the patient's home. They do the refurbishing, the cleaning, and they manage the inventory. So you select those, and then what kind of reporting you want, and so on and so forth. Again, I encourage you to use those tools, and again, give us your feedback. I'm leaning towards providing or doing a portfolio on medication management, because that's where I feel we need to sort of complete that sort of trio regarding healthcare services. But I would encourage you to give me your feedback on these tools, and would love to hear your thoughts. I provided you with the link to the survey. And also we collected case studies. We have 6 outstanding case studies. One of them is from a rural provider that not only did a pilot and tested the technology, they partnered with Philips, but they also advocated at the state level and managed to get telehealth to be reimbursable in their state under the state Medicaid waiver program. So, and there are now 6 states that do reimburse longer-term home telehealth under Medicaid waiver programs for older adults that are nursing home eligible, who are also Medicaid eligible. That's a link to the full initiative. I highly encourage you to pilot test telehealth and RPM, use it to improve care and demonstrate your competencies, and then partner with hospitals, ACOs, and payers, and see if you can get contractual agreement outside of the fee-for-service modality that we're being squeezed out of, so to speak. So with that, I thank you for your attention, and I do apologize again for the internet mishap we have. Thanks.